So what we were able to do was bring the entire care team together. We took members of the secretarial staff, the members of the desk scheduling staff, the members from our care providers and our physicians, and we got all together and partnered with the CFI team so that we could try and understand what is it about the practice that we like, what is it about the practice that works, and where are areas that are kind of, shall we say, those touch points, those things that bring upon frustration with our daily ability to do what we need to do and to do it well. And so then we were able to collate a list of here's what works and here are the areas that are challenging. And when we came up with that list, it was very interesting. There were 5 major themes that became apparent. We found that we weren't necessarily working as a cohesive, consistent team. We found we had challenges with scheduling. We had found that we also had challenges with patient flow, meaning right patient, right location, and executing what the plan was. We also found that we needed to start to look at standardizing our practices amongst the providers. We are at prototyping right now, and it's really kind of exciting. So we did do all the brainstorming, the observational research, and now we have what we call the co-design team. The co-design team represents 2 individuals from each of our small subgroups, and we've gotten together to look at what are going to be some of the things that we prototype in terms of implementing and trying to help enhance our practice. I think one of the most surprising things that we found is that when the provider, the physician, is sitting down, so you've seen the patient, you've interviewed the parents, you've come up with a diagnosis and a management plan, and you're interacting with the family and you're making this recommendation, and you have 2 small children in the room, and the parents are trying to concentrate on what the physician is saying, and the parents are also trying to concentrate on engaging their child, and their child is distracted or distraught from the examination or just glad it's over. And so we found that the parents weren't necessarily observing and absorbing all the information that even the physician was trying to provide from them, and it was just complete and utter chaos. And from this observational process, what we're finding is that we need better mechanisms in which we can engage the child in another activity while the physician can concentrate on delivering the information back to the parent. And one of the challenges when we look at the flow of our practice is inevitably you sit down, you talk to a family, and you say, this is the surgical procedure your child needs. You explain the risk, the benefit, the rationale, and what the potential complications are. And they may only hear half of it because they're so distracted. And so one of the other things that we're going to look at prototyping is how might we be able to provide an environment for the parent and the physician to interact, yet distract the child, so we can increase the parent's ability to absorb the information. And we anticipate that the downstream effect from this will be tremendous in terms of decreasing the number of phone calls back to the provider after surgery, or the number of phone calls back to our office in between the time we see the patient and the time of the surgery. We also feel that it will be able to better engage the parents in the education in terms of what they need to do to manage and take care of their child after surgery. And so if we can get into a routine of prototyping these kind of very, standardization, which was one of the themes that we discovered in our observational research process and our brainstorming, of standardizing that, then you can just redistribute the work so it's not heavy on one person to do, and it becomes a very routine thing. For example, like if we were to prototype standardizing seeing a child straightforward, healthy, needs bilateral myringotomy and tube placement for adenoidectomy. I mean, right now with the paperwork entailed, seeing the patient, doing the clinical documentation, it takes me 15 to 20 minutes to do that. The operation itself takes 3 to 5 minutes to do that. So if you weigh the time difference here, it's substantial when you look in terms of a time investment. Perhaps one of the things we might be able to prototype would be we give the parent an ability to enter some information into a repository about the standard questions that I would ask about otitis media. That could be then entered into a computer and I could walk into a room. I'm just designing a prototype in my head here, whereby that information pops up, I could review it with the parent and do the examination, and we could talk about these are the reasons why your child would benefit from having tubes, and then we could have some interactive computer model that would explain the surgical procedure and the process to the parent, which would then take me out of the loop to do that part of it, and then they could have a visual feedback. It could allow them to do that, while we could take the kid and put them in their kid zone and have them distracted. You know, and so I could be on to seeing another patient, yet we're still meeting the educational need for the patient. And so that could perhaps cut down the 15 to 20 minutes that I take to do that part into a physician effort of maybe 3 to 5 minutes, but still accomplish the same thing.